others that I have. We're not even going to go over the lecture objectives. You can read those on your own time. Headaches. Headaches, very, very important, very, very common. Be able to recognize when you need to worry about it. So, localization of the meninges. Meningeal stretch is what causes your head to hurt. The most important things that you need to worry about is it due to an infection? Is it due to something that's not supposed to be there anatomically? Somebody just got on the background.
I think she's in
I thought they were just opening it. So obviously you've got a mass, which is a zebra, but again, you've got to think about it and rule it out. Increased intracranial pressure due to a tumor or something that's growing within the ventricles or even within the actual, sorry. I didn't eat, but I just drank Coke, and so I was the actual brain matter itself. Low intracranial pressure, so if you've got a post-LP headache, it's going to be a positional headache. Somebody that's had a lumbar puncture and they took too much off, so, and that varies. You're never going to know who's going to have that and who's not. Some people you can just take 4 or 5 cc's off and automatically they've got a headache. And some people a lot. What you can, obviously, anytime you're doing that, that's always a risk, so you better explain that to them, and you're going to explain to them when to really worry about it and what to do. If you've got a post-LP headache, lay down as flat as you can. You can lay on either side, you can roll side to side, you can lay on your stomach. Just don't elevate your head above your heart level. And then have them drink caffeine. 85% of those will resolve on their own, but then the ones that don't, they have to have a blood patch and go in and actually anesthesia goes in and just injects their own blood into that area to clog that off. All right. And then traumatic dural tear, obviously, that would most commonly be from neurological surgery. I guess you could probably get that from a fall or anything like that as well, but that would be somebody that goes in exploratory and figures that out. Meningeal irritation, again, meningitis, which is an infection, acute or chronic, and then subarachnoid hemorrhage. He had tons of abbreviations, so that's what I did today, is to make sure you knew what those are, because SAH, I was like, I'm pretty sure not everybody knows that. So I'm throwing that all in there for you guys. Meningeal ischemia, so decreased blood flow, whether it's a vasospasm around the temporal artery, which is what the giant cell arteritis is. Usually patients greater than 50 years of age, that information is not in there, but especially think about it if they're more than 60, 70, and 80, it even goes up even more fast. Meningeal sensitization, so chemical changes, somebody that's been on medications for headaches and then they stop that medication, or even caffeine, think about that. Analgesics, so somebody that takes anti-inflammatories for a musculoskeletal injury for a long period of time, and then they're gotten better, but instead of tapering down off of that, they just quit it, and so then they're going to have a headache that lasts for days. It's not going to be excruciating like a migraine, maybe you throw up, but it's going to be very annoying. And just make sure that you think of that. Have you been on anything that you've taken, daily for the past 10 days and then you stopped it? Caffeine being one, Tylenol. Opioids will do this especially too. Somebody that's been on an opioid even for a short period of time, if they stop it all at once, sometimes they'll get a withdrawal headache essentially. So think of those things and don't just jump into you go brain tumor. Differential diagnosis, again, primary headache condition in which the headache is a primary manifestation, such as a tension or a cluster headache, or a chronic condition with recurrent attacks. So people can just have regular headaches persistently or chronically, but not necessarily migraines. Migraines have a different definition. Secondary headache, again, that's conditions caused by something else underlying. know these. Red flags for secondary headaches caused by something else that you need to worry about. They say this is the first serious headache I've ever had. This is the first time I've ever been to the ER for a headache. Or it's the worst headache of my entire life. Or it came on all of a sudden. You know, even somebody was saying it's almost like somebody snapped their finger and it was there. I was perfectly fine and then bam, I was thrown up in the bathroom. Progression or fundamental change in the pattern of their headache. So if they've had a headache that's gone on for a few hours, but then all of a sudden it changed drastically. A new headache in somebody that's less than 5 years of age, very rare, but you need to work that up a lot because it is so rare, there's probably something going on. And then somebody that's got a new onset of headache greater than 50 years of age. Those don't have to be severe as well. You can be thinking of, MS will cause a headache, and it could just be a mild one, and that's one of the first symptoms that they'll complain of. All right, new headache with cancer, immunosuppressive agents, so steroids, or even pregnancy, because our hormones affect a lot. You can have hormonal headaches, just like people with menstrual cramps who get a headache or perimenstrual migraines. Headaches with syncope or seizures, obviously more CNS involvement, so be a little bit more apt to work this up early. Headaches triggered by exertions, somebody that's vigorously exercising, changing their oxygen saturation. Valsalva maneuver, again, I guess bearing down to go to the restroom because you're having a little bit of hypoxia. You're also changing those baroreceptors in the carotid arteries, changing your blood pressure. Drastic changes in your blood pressure causes headaches, whether it's up or down. Seizure, wrong side. Sex. Again, some people hold their breath for that. We saw that with the forensics. Thank you. I was like, death lecture. I know I called it that. It's a little cold. All right. So, again, hypoxia. So, what would be your first initial treatment if the patient comes to the ER complaining of headache?
You need to figure out what,
Oxygen is your first treatment, regardless of what they're treating, because hypoxia is one of the most common causes. So that's a very easy thing. You're not going to hurt them. I don't care if they say they're allergic to oxygen. It's not going to hurt them, except for your patients that are COPD that are on oxygen all the time. So 2 liters of nasal cannula, still not going to hurt those COPDers as well. Just start with that. You've already done something for them. They feel that you're paying a lot of attention, and you may already be starting that treatment while you're talking to them. Okay? All right. Neurological symptoms lasting longer than an hour. Pay more attention to those. Abnormal general neurologic examination. So, tumors, strokes, they're going to have a headache. Not always, but if they do, and they have neurological findings on their exams, and that substantiates even more so when you be working that up thoroughly. 5% of those presenting to the ER with a brain tumor or other structural neurosurgical disorder with a headache, and none of them as a sole concern. So they came to the ER with the brain tumor or a neurosurgical disorder but didn't complain about a headache. 5% of them don't have a headache. So just because they don't have one doesn't mean they can't have those ending diagnoses. A secondary headache, we'll kind of go through these. So Pseudotumor Cerebri, also known as idiopathic intracranial hypertension. It's not actually a tumor. They just have an increased production of pressure in the ventricles. So they'll have the headache, they'll have the papilledema, and they'll have visual changes, visual loss. Those are your 3 hallmarks for pseudotumor cerebri. Headache 75 to 99%, usually daily. Worse with exertion or Valsalva, which exertion always causes those same kinds of effects. And then migraines are common as well. More common in women, most obese, and then most are of childbearing age, which we learned yesterday was 7 to 65, so we'll add a whole lot. Peak age, 21 to 34 years. So diplopia, double vision, 6th cranial nerve palsy as well. So checking and asking specifically, not just do you have any visual changes. Do you have double vision? Do you have blurred vision? Have you noticed that you can't see out here or feel like you're having tunnel vision, or that you're looking through binoculars incorrectly and you're not able to see all the fields? Transient visual obscurations. So this is postural, blacking out of vision. So like when you bend over to tie your shoes or whatever, and then all of a sudden you notice that you can't see a certain area of vision, and then you can reproduce that. That's something to be concerned about. That's something that your patients will report to you, and you need to be able to identify that and recognize, oh, we need to be thinking of Pseudotumor Cerebri with that. Pulsatile tinnitus, so the ringing in the ears, but it's with the pulse. Okay? Not just ringing, monotonous, ongoing. And then dysthymia. So make sure that any person that comes in complaining of a headache, that you do a fundoscopy examination. I don't care if you just saw them yesterday for that. Look again. This is a normal cup to disc ratio. This is papillary edema. There's no demarked edges to know where the optic disc starts and ends. It's kind of just fluffled out. And you can't really tell the cup to disc ratio because you can't even differentiate those two structures. All right. Dandy criteria for increased intracranial hypertension. I'm sorry, idiopathic intracranial hypertension. I said that wrong. Localized neurological signs, so your patient's alert, then they've got that double vision. Neuro imaging studies, except for small ventricles or an empty sella turcica on their CT. Or an MRI, I guess. MRI, not CT. MRI is soft tissue, CT is bones. Documented increased intracranial pressure. So again, these patients may have already gotten a workup that didn't have a definitive diagnosis given to them, but they were told that the opening pressure on their lumbar puncture was increased. So they knew that they had increased intracranial pressure. The amount of fluid, as far as the components of that being all the other parameters, the protein, the glucose, and that, was not differentiated or not abnormal. Primary structural or systemic causes of elevated intracranial venous sinus pressure excluded. So obviously, if you have meningitis, that's going to increase your pressure, your opening pressure is going to be increased. So if you've got meningitis and all the parameters look like meningitis, then that rules the IH out. And then the central venous thrombosis, which is a clot within the cerebral veins, sorry. Your workup, again, look in the eyes, we've already said that. MRI, MRV, I've never ordered one of those. I guess that's similar to an MRA, only it's the venous instead of the arterial. Doing this prior to an LP, unless you're worried about meningitis. Again, if you're worried about meningitis, make sure that they don't have papilledema, and if that's negative, then do your LP. Always you're measuring the opening pressure when the patient's in the lateral decubitus position. You cannot measure opening pressure if they're sitting up. So an LP done, like in an epidural on a pregnant lady is done with them sitting up, you cannot do opening pressure. That's not accurate. That's not an accurate reading. They're always going to be laying on one side with the knees bent a little, doing that position. Lateral decubitus, that's what that means. This again is the tubes, consistent with the other slide that I've already given you. Ruling out infections, inflammatory, as well as tumor processes. And then your opening pressure should be greater than 25. If it's really, really high, then that's indicative of meningitis. Treatment, so 1 to 2 grams of acetazolamide, which is for, again, idiopathic intracranial hypertension or pseudotumor cerebri. And then you're referring them to a neuro-ophthalmologist or neurologist, and then obviously the preferred is the neuro-ophthalmologist. They are going to do the nerve sheet fenestration, and you're not going to be working on any of that, and the shunting. So if you go into neuro, then you can work on that. But I don't have to do that. Case presentation: 32-year-old obese woman presents with a history of daily headaches for 3 months. Noted brief blackouts of vision in either eye every time that she bends over to tie her shoes. For the past month, she's had noticed pulsatile whooshing sound in her right ear. Neurological exam was normal, with the exception of elevated optic discs. Elevated optic discs just means when you look fundoscopically that they were higher than what you usually see in a patient. That doesn't mean papilledema. It would say papilledema if it were. And then she has a few hemorrhages seen on fundoscopic visual fields. Performed by optometrist in the office is normal. MRI of the brain is normal. What is your next step to evaluate further discovery of this headache? And how do you do that? LP. Thank you. It was that slide and I took it out. So if that's correct. I moved it because I forgot that it went with that as well. Because I thought it went more appropriate down after I explained what an LP was. Sorry about that. The LP is the right answer, yes.
So there's a bit of a difference on how to test the tubes for a lumbar puncture on this one compared to the sepsis one. Which one should we go off of?
What's your variation?
Like this one, this lecture says hold tube 3, and I think the other one says hold tube.
Holding. Yeah, the only difference. Sometimes you only get 3 tubes, and that's probably what
so it's just based on how
depends on how much volume you can get. Also, if you do an LP for you're highly suspicious of idiopathic pseudotumor cerebri, I keep saying it wrong. You're not really worried about an infection, so you're not going to do the gram stain and the other that I have put on tube 3. So you may not even need to do, you don't need to get as many tubes, is what they're saying.
That makes sense.
Okay. Giant cell arteritis. So you guys have already learned this. There's a lot of details in this. Do you guys have any questions or concerns with temporal arteritis or giant cell arteritis? They love to ask this on your boards. Just be familiar with it. You're not going to see it. It's rare. My grandmother actually had it, but all of my family members do great things. So it is still, it's rare. So just know, if you're highly suspicious of it, get it. What's the definitive diagnosis? Yes?
Sorry, going back to the lumbar puncture really quickly. The last bullet, you said opening pressure should be greater than 25 millimeters O2, but on a prior slide you said 250 for ICP.
That might be a typo.
So is it supposed to be 250? 250?
It's 25 is normal. Send me an email right now for me to look that up. Thank you. You guys put me right back where I was. Thank you. So, right, and the treatment, high-dose steroids. So that's over on management. You're working it up. You're doing the biopsy. You're also doing the CRP and ESR, which are very broad. First thing, because if those aren't elevated, then you don't need the biopsy, which is very invasive, obviously. So do those first. That's not meaning that you're going to get a diagnosis, but it's not going to be giant cell arteritis if those are normal. That's the main reason. And the high-dose prednisone almost works immediately. It's amazing. You know. All right. Subarachnoid hemorrhage. Subarachnoid. Know your anatomy. Know the space. Know whether this is intracranial, extracranial, where it's at. Okay. Headaches due to meningeal irritation. It's a sudden onset. But yet it says migraine is gradual. That just is so contradictory. Worst headache of my life. Nausea and vomiting, photophobia. So with most migraine patients, they're going to come in with their sunglasses on. They can have loss of consciousness. They don't have to have had. Neck pain, nuchal rigidity are also going to worry you about meningitis, but those are the things with the subarachnoid hemorrhage. For some reason, they get symptoms in their neck as well. And then seizures in 10 to 25%, which is actually 10 to 25% of subarachnoid hemorrhages, not 10 to 25% of patients that present with a headache. Make sure you understand those statistics. The workup for a subarachnoid hemorrhage, CT and CTA, so that you can find out what artery is being affected and which area, especially if you're worried about an aneurysm. And that's what causes your bleeding in the subarachnoid space. CBC, CMP, coag panel, again, those are all because you're working them up, because you're going to be sending them to the surgeon to be monitored, but you also got to know in preparation what you have on standby. If they're already low with anemia, their H&H is really, really low, or their platelet count's really, really low, and they're not going to be able to clot off. Their coagulation panel is going to be abnormal. What's a coag panel? Say it really loud. Now, what are the tests? PT, INR, and PTT. Okay. They don't hardly ever do the bleeding time anymore. That used to be part of it, not anymore. Okay, and then make sure you get your blood type and screen. So type and cross match is what I write it as. Type and cross match, usually times 2 units if I'm having them get blood ready. Always. That's my standard order. Because it takes a long time for them to get that process, and if you're worried about a patient crumping in the ER, and that's for anything, trauma, sepsis, if you're worried about hypovolemia and then having also some bleeding secondary. If you're going to need, not sepsis, it was our ectopic pregnancy girl yesterday. It takes hours for them to get that ready and matched if you've got a patient that's got a rare blood type as well as a lot of antibodies. And you're going to do them worse if you don't match those antibodies. So get it ordered. If they don't use it, great. They've done work. Sorry, they've done extra work. But when you don't order it and you're not prepared, you're going to need it and you're going to be up to have it. And they're not going to be as responsive. And then you're going to have a young female that got the universal donor, but also got a lot of antibodies, and now she can't get pregnant because of all of those antibodies. Okay? Or she keeps having miscarriages because of it. So LP if needed, and then your EKG. So a subarachnoid hemorrhage, if you've got frank blood and it's not just a little pink and it just looks like all blood, that's definitively a subarachnoid hemorrhage until proven otherwise. That's why LP is one of the early things that you do for a subarachnoid hemorrhage. But be highly suspicious that that's what's going on and not a herniation or other problems. Airways, breathing, circulation, always make sure that you've got those under control before you're doing the other. Neuro consult, and then making sure that you're using pressors to keep their blood pressure up. Again, this is a aneurysm that's burst. The neurosurgeon is going to need to consult for them to determine if they need to do a procedure. Subarachnoid hemorrhage does not increase the intracranial pressure. That's why it's okay to do the LP. Again, make sure that you are certain that their symptoms are very conducive and going along with the subarachnoid hemorrhage, not one with intracranial pressure. So make sure they do not have papilledema. The rest of this is people that are actually going to be going into neuro, but know that mannitol, you are going to be using that to decrease the intracranial pressure. Obviously, you're going to be consulting neuro because you can use it too early though and cause some problems. Treating seizures, again, these are more maintenance-wise, prophylactic, that are going to be on a daily dose of Keppra or valproic acid. This is Dipicon instead of Dipicote anymore. Thunderclap headache. Sudden onset, worst headache of my life. So I'm thinking that that sudden onset is wrong. And we'll also get back to you. Wait, I got you.
No, I think we learned that it's sudden onset for subarachnoid.
Okay. Why did they say migraine is gradual?
Maybe it just means that the headache's sudden, but then it gradually gets worse.
I think this is like presentation on it could be ICH or subarachnoid.
Is it just like the migraine is gradual onset?
Maybe. See, I didn't make that slide, so I don't understand it, and it's confusing me. That's the only bad thing about you. Somebody else can hear it. All right. Thunderclap headache again. Sudden onset, worst headache of my life. Ruptured, unruptured aneurysms. Most common cause, again, subarachnoid bleed. So this is the same thing that we're talking about. But the other thing it could be is the cerebral venous sinus thrombosis. These are your differentials that you've also got to be thinking of. Vertebral dissection, which is very, very rare. Acute hypertension, and then low CSF pressure. Even psychiatric conditions, I think. All right. Migraines are very, very common, especially when you consider the tension types to be migraine. Sorry, I didn't know that. The migraine definition, syndrome of episodic brain dysfunction with systemic manifestations, which may include a headache. But systemic meaning nausea, vomiting, visual changes, scotoma, aura, sometimes even stroke-type paresthesias or motor functions that returns can be a migraine. Those scare the dickens out of you and they get a big workup, but it's still going to be a migraine. Can be genetic. So patients that come in and say, my mom had headaches, my sister had headaches, they're at an increased risk of also developing headaches, migraines, sorry. And then people have having transient episodes, attacks of brain dysfunction. So, like I was saying, the motor deficits and sensory deficits. I already talked about it. Mimicking a stroke, TIAs, focal neurological symptoms, GI symptoms with nausea and vomiting, sometimes diarrhea, constipation, chest pain. They can have chest pain with that, but make sure that you're ruling it out. Do the EKG, do the cardiac enzymes or biomarkers, make sure those are negative. Sinus headaches, don't just assume because a patient says that they have a sinus headache and sinus congestion that it's the same thing. If they've got a really, really bad headache, you better be trying to transilluminate the sinuses, palpate on the sinuses, but most importantly, do your fundoscopic exam. Make sure you don't miss something big with that. And again, triggered, so anything that triggers your headache, that's why you're asking your questions, just asking what if they're close to starting their period, those things. 4 possible phases, again, prodrome, aura, pain, and then postdrome. So the prodrome could just be that they're really, really tired. Sometimes people have weird ones that they'll come up with, but believe them, they know their body more than anybody else. An aura, a lot of the times a little scotoma lights or even peripheral visual changes, and then the severe pain. And then the postdrome is kind of like post-traumatic neuralgia, just tenderness. They'll complain that their scalp is hurting, their hair is hurting, and just, or even depending on how long they've had the migraine. But they'll tell you all of that is present. Typically in the emergency room, IV, IM, intranasal, and rectal medications can be used. Depending on how long they've had the headache, makes my decision on what I use, depending on how many times I have seen them, depending on what they've tried in the past, and depending on what they're currently on, so if they're on something maintenance-wise. I take all of that into consideration before I decide what to use to treat these patients. A lot of the time my go-to is IM, oral, and Benign. Only problem with that sometimes is that IM takes 45 minutes to an hour, so it depends on how big your ER is and how busy you are, and sometimes you don't want to wait and watch for them to have a response, because you cannot just give them a shot and send them home and they have no change, and you don't know if that's really what it was. Okay. That's why we sometimes will go to the IV, so you get a quicker response, document that, document the patient's reaction, knowing that that's getting better. Intranasal is faster than IM as well. Rectal I've actually never used, so I don't know what practice-wise how often that's used. Gastroparesis, of course, somebody with nausea and vomiting, you're not going to give them anything PO. That takes so much longer for that to work as well. It's just not as effective. So your triptans, that's why they've got the injections. We've used those in the ER as well. We give them a shot of an ergotamine. And then most commonly, because the migraines are almost always caused by this. You guys have had the migraine, right? Let's go a little bit faster here. Here's your treatment. Block, block, block. Ergotamine combinations. I'm not going to make you know these doses. Just know that they're used for that. Again, cornerstone of migraine treatment, hydration, oxygen. Sometimes dehydration, so knowing what that is. If they've stopped caffeine, how are they dehydrated? Have they been sick with other elements that are causing the headache? Do they have a fever? A fever alone is going to give you body aches and headaches. So think of those things and don't just jump on the migraine. And then giving them fluids and maintenance it off. Adverse drug reactions, again, fluid overload and hypovolemia. Just make sure that they don't already have a low potassium and you're trying to throw all the fluids on them. And make sure that they're not at risk for congestive heart failure or problems with fluid overload because their kidneys are not functioning as well. So, magnesium sulfate, never used it for a migraine. Maybe probably those that are just really, really hard to treat. The only thing that I would add, Depicon is something that's used a lot for maintenance, but usually it's the neurologist that starts it. I don't start that in the ER, so you're not going to need to know that for the ER. The other anti-seizure medications, you're certainly not going to be doing those in the ER either. As far as antiemetics, which is what these are, phenothiazines, compazine gives a ton load of patients. Side effects of dystonia and just jerking, and it freaks them out because they think they're having a seizure but they're awake. So they don't like it, and then they'll say they're allergic to it. It's not that they're allergic, it's just that that's just a common side effect. And so I don't use it for that reason. Phenergan IV causes a lot of problems with destroying the vessels if you're not doing it right, as well as a lot of people have that reaction. So we don't give it IV anymore either. That might be where you're using rectal now. No, there it is, rectally available. Phenergan rub on the wrists, so I'll use that quite a bit rather than. But obviously Zofran now is on the market, and YB is going to much rather use Zofran IV. I don't know why it's not on this slide. Compazine and Phenergan are not my first choices anymore if I want something stronger or a faster acting than the IM. Reglan, again, that one also is bad. Dystonia, jerking. Oh, it says 25% right there. Not a fun thing to go through, and patients will be angry with you. NSAIDs obviously is the #1 treatment, and then your ergotamines. Naproxen there is not Midol and Aleve. It's naproxen. Which naproxen sodium is what Midol and Aleve are, but naproxen is naproxen, but not naproxen sodium, which is so confusing. So just naproxen never really works for any patients that I've ever. They just laugh at me and go, roll their eyes, literally, roll their eyes at me. Do not give narcotics for migraine, period. They don't work, and you're going to just cause a drug addict, and they'll be your best friend. Come in and see you every time you're on shift. Steroids. I use steroids a lot with migraines, especially when you've got somebody that's had them for days, because it stops the relapse, and it will also stop that cyclic inflammation. So I will give a shot of steroid, the Decadron, with the Toradol, with the Zofran. Dizziness. All right. Dizziness has tons of definitions from patients, and your little old ladies are going to have descriptions of things that are way off base. Just nail it down. Does that mean room spinning, you're spinning? Does it only occur when you move? When you move just your head? Or when you go from a sitting to standing position? Or when you roll over in bed? Specifically ask those questions, because that's going to help you narrow it down to be something that you need to really worry about, or if it's just, plain vertigo or an inner ear infection. All right. So they'll use all of those different words. Off balance, feel weird. Find out what makes it worse. When I bend over to tie my shoes, or when I look up, I don't know why, put my contacts in, is what one patient kept saying. And then again, go through those visual changes. Do you have double vision? Do you have visual field loss? Do you have numbness or tingling along with that, or shortness of breath, so that you make sure that you're not actually having cardiac problems or stroke? Walk the patient to do your full neurological exam, as well as watching them ambulate. See if they're ataxic, see if there's cerebellar involvement going on. Dick's Halter is an Apley maneuver. Do you guys know what that is? Okay. If you don't, you can look it up and watch on YouTube. They've got some pretty good videos. Use that to definitively determine what's causing their dizziness. Orthostatic vital signs need to be done correctly. Do you guys understand? So you do lying, sitting, and standing, 5 minutes apart. So you have them lay down for 5 minutes before you do it. You don't just lay them down and take their blood pressure immediately. And you have to couple that with blood pressure and pulse. So you lay them down, tell them to relax, turn the light out, give them something to drink, something to occupy them for 5 minutes. Do their blood pressure and pulse. Bring your nurse station if your nurses will do this with your inmates. Then sit them up 3 to 5 minutes, if I did say 5, 3 to 5 minutes. And then stand them up and make sure that you are helping them and you're standing right there with them. Don't walk out of the room. All right. EKG, cardiac enzymes, we already talked about that. CBC, making sure that they're not having a volume problems causing their dizziness, hypovolemia, anemia, severe anemias. CMP, BMP, you want to be looking at their electrolytes. Do they have an electrolyte disturbance that's causing their dizziness? And then definitely correlate it with their age and their past medical history. Again, to determine what else you need to order that would be causing the dizziness. And diabetics, make sure their glucose isn't completely out of range. And then do you need imaging? So CT of the head, or CTA, which is what the arteries in your MRI. Is it vertigo? Vertigo is a sensation of motion without movement. So you're just essentially laying there and then all of a sudden it feels like your body just doesn't flip. That's the difference between dizziness and vertigo. Vertigo can be a sudden onset and be very, very severe as well, immediately. Causes of dizziness, some last seconds, some last hours, okay? With Bppv, benign paroxysmal positional vertigo. This is the one where your ossicles kind of get in the wrong position, dislocated. This is where when you do your echoes in your work, you guys probably saw all of this. This is a case that you can read on Bppv. Make sure, again, you're ruling out any cardiac reasons, that they don't have any arrhythmia causing them to have a drop in their blood pressure causing them to be dizzy. All right. Again, that's the case. You guys can read through that. Watching the rotary nystagmus with the maneuvers, and then also there's one that's the one where you have them look up, and then their one eye lags the other. I think it's here's the maneuver, it goes through that. Meclizine doesn't work, that's the biggest thing out of this slide. Here's the Epley maneuver itself, and then this is the different variations in time. So your differential Bppv is in seconds. Benign orthostatic hypotension, seconds to minutes, this dizziness lasts. And then reflex syncope, seconds to minutes. Panic attacks, minutes to hours, depending on how upset they are. Meniere's disease, minutes to hours. My mother-in-law has Meniere's disease, and she gets vertigo for hours on end, but it's very, very sudden. She'll end up just being perfectly fine, bend over to do the laundry, pick up the box, do all the laundry, and end up on the floor and immediately start throwing up, and then be able to follow the bathroom. She also has diabetes, which is kind of a double whammy, but at least it's type 2, not type 1, where she gets into PKA. All right. So dangerous mimics that are less common, TIA, cardiac arrhythmia, but make sure you take in all of these. One of my major things is I got a little lady coming into the ER with dizziness. I'm darn well getting an EKG, always rule that out. Vestibular neuritis, so post-viral or viral syndrome. There's a lot of things that we have that are caused after we have a virus. This is one of them. It's very similar to Bell's palsy, but you get the facial palsy and after having herpes simplex. That one's called Ramsey-Hunt syndrome. Just be familiar that you've heard that because it might be on your board. There's the head impulse test. That's the one where you're jerking this way and their eyes go that direction, but you have them tell them to look at your nose and stay looking at their nose. When you go the way that it doesn't, their eyes will stay at your nose. But if it's positive, their eyes will jerk the direction that you throw them and they'll jerk back to the nose focus. Treatment, supportive care, so fluids, and steroids. Time to recovery, 6 months, not fun. There it shows that maneuver. A stroke versus vestibular neuritis, so they've got it on both sides there. Mainly vestibular neuritis, you're not going to have any neurological focal symptoms. vestibular neuritis here, your nystagmus is going to be away from the lesion. With a stroke, that head impulse test is going to be normal. That's the skew deviation, is when you have them look up and their one eye is lagging the other. That's present in a stroke, not present in vestibular neuritis. So this just differentiates how to determine whether it's a stroke or BN. Here's a case study. You can read through that, test yourself, and see if you understand it. Be able to differentiate those two, okay? A stroke is a sudden brain dysfunction due to blood vessel occlusion or rupture. So a lot of patients are still confused between a headache or a heart attack and a stroke. I always just simplify it. A stroke is in your brain where blood vessels getting blocked or breaking. Heart is blood arteries that supply the muscle of the heart get blocked or rupture. And that's a heart attack. Do you guys have an understanding of TIAs and strokes when we go through this? Okay. Where to locate it? This is very, very, very detailed. If you guys are still having trouble with trying to figure out, is it middle cerebral, right cerebral, post-cerebral arteries? Do you guys have that down?
We covered it in neuro.
We covered it in neuro. Here it is again. So you've got the anterior circulation being the opposite side of the body is going to be affected of where it's at in the brain. Okay? So you're going to have aphasia, which is what? And then if it's the left hemisphere MCA, then it's the right hemiparesis and hemisensory. So numbness and tingling in that area on the opposite side if it's the MC. Know the right homonymous hemianopsia. Know how to differentiate those. I can guarantee you that's going to be somewhere on your boards. I'm pretty sure there's a question on the test with this as well. So know this slide. And then there's some pictures to kind of go along with it to help you to see what it is in the brain and what it looks like on the body. ACA, so your anterior cerebral arteries. This is the opposite side of the body again, but the frontal lobe, so your personality changes. And then there's your posterior. Okay. Posterior, again, is going to affect a lot of your dizziness and vision, because your vision is occipital and your balance and everything is cerebral. Your posterior quadrant is cerebellum. There's a picture of your anatomy if that helps you understand. And then your small vessel syndromes of the stroke, which are also known as lacunar infarcts, really deep into the body. You're not going to have as much as immediate onset. It's kind of going to be gradual, but it's definitely going to be obvious. This is contralateral hemiparesis, which is the sensory and numbness, as well as motor. All right, code stroke, do you guys understand FAST? The acronym for that. So FAST stands for facial asymmetry, aphasia, difficulty with talking. S is arms. Yeah.
A is arms, S is speech.
Oh, I did it backwards. That's why I was messed up on my pen. How is it? Okay, so A is arms, with them having, you have them hold their arms up, close their eyes, and they're going to drop off and not be able to hold them straight. And you can do this with them laying down in the bed even. tilt their head up just a little bit. They don't have to be standing. You certainly don't want to be standing somebody that's not able to fully function. And then T is timing. Know the timing of the onset and how much time has progressed. And what is your limit on time for using a clot buster? 4 hours. 4 hours. 3. Pretty sure it's 3. Google it, unless it's changed recently. So that acronym, the ACLS book, if you guys ever buy one, will have a card, and so on one side will be all your ACLS medications and algorithms, and on the other side will be a stroke algorithm, and that will be on there. Make sure as well, with the stroke, the other thing I want you to absolutely know is check their glucose. Make sure that their glucose is normal prior to giving TPA. Otherwise, you're going to cause a hypoglycemic effect, and they're going to be even more mentally altered, and that's going to screw up your assessment of what's really going on. You're not going to have improvement, and you're not going to know why, because you're not going to think low sugar. All right? It says EKG is no longer needed prior to using TPA. I guess they were looking for, because they would be on a blood thinner. I don't know. Obviously, stroke treatment, if they've got high blood pressure, you're not going to jump on them with vasopressor and try to drop that. If you drop it too low again, you're going to cause problems with even less cerebral perfusion and more damage to that brain tissue. Know that. You're not going to have to know the dosage of TPA. Highly unlikely that you're going to use it because you're going to be in the city. You're going to do rule on rotations. I would study it if you go to the ER. On ER rotation, you will know before you go because they're going to be asking you those questions. Even if they don't end up using it, they're going to want you to know, and they're probably going to pimp you on it, so it would be a good thing to know. All right, intra-arterial treatment, obviously the neurologist is going to be doing that. That's when they go in and either go and suck the clot out, or clot evacuation is what that's called, or extraction, and then also the wiring where they no, that's for an injury, I'm sorry, I went off. These are your cases. Again, here's a case of a CT, the head. Very, very hard to see that. There's one in here where they're showing the CTA, so you can see the arteries and the arrow sign showing you where the occlusion is. It's just because there's supposed to be flow going through there, and there's not. And you can see the white dot there is where the actual embolism is. There's one that's been removed. This is after post-embolectomy where you've got reperfusion. So they'll show you the before and after. So this is before. See where the arrow is. There's nothing coming through that. And then afterwards, see how the change, drastic change in the blood flow. NIHSS is your scoring according to therapy. Again, if you're going to do neurosurgery or be in neuro or be at a stroke center. Where's the stroke center here in Oklahoma? You guys know? It's Baptist. Baptist. So if you have rotation there you go. Especially if you do internal medicine, you're probably going to get some of this. So study this stuff before you go. All right. Transfer protocol, this is if you're in a rural area, there's going to be indications, contraindications, knowing when to determine whether or not they're stable or not. He obviously was upset with some of the transfers not being done appropriately, so he wrote it all out for you guys. So if you guys are going to be in the rural area, just know that those are all the stops of what you need to have filled out in the paperwork and information that you need to send. So stroke care in a hospital. Obviously, you're going to have your immediate care from the neurologist, whether they're going in and doing the clot cluster or going in and removing the clot to reperfuse that area and minimize the amount of damage and blood loss supplied to that portion of the brain. But then you also have your rehabilitation. So you can have occupational therapy, physical therapy to increase the movement of whether it is motor, loss of limbs, speech therapy, if they've got the prolonged dysphasic effects, and occupational therapy, of course, goes along hand in hand with both of those. Prevention of strokes, teaching, education, obviously, so your risks for having a stroke, make sure that they're staying on their antithrombin medication, keeping their blood pressure down under control so that they're not having a hemorrhagic stroke, that they're keeping their lipids low. It's what the HLD, hyperlipidemia, is how he's abbreviated that. And then diabetes under control, because that goes hand in hand with vascular abnormalities, as you guys have all seen. Cigarettes, because the nicotine causes vasoconstriction, so as it's an increased risk for heart attacks, it's also an increased risk for embolic strokes. And alcohol for hemorrhagic strokes, because it is essentially a blood thinner, as well as problems with your clotting factors once it destroys your liver. So both ends of the spectrum there. BMI, obesity, obviously increases your risk because you've got obesity, then you're obviously at a higher risk for developing hypertension and diabetes. All of that starts running together, and this is where your internal medicine is going to come in. You're going to have what we call train wrecks in the ER, where you've got to multiple manage a lot of comorbidities. Making sure you're looking at everything and everything is being attended to. I do not know what CAS is. CEA is a cancer blood screen. What's CAS? I don't know where that question mark, maybe I put that there last night when I was tired, because I didn't know what it was.
Maybe carotid arteries.
Coronary stenosis. Coronary artery stenosis or coronary artery disease, maybe.
Syndrome?
Syndrome? Syndrome? Coronary artery syndrome. All right. So your evaluation, obviously, as well, trying to find out where the source of that clot is, because if it's continuing to be unstable, you're at a higher risk for throwing more clots and having more strokes, right? So if you've got atrial fib, you want to get that under control, make sure that they're on the correct dosage for the antithrombin, making sure that you're looking elsewhere if that's not the case. Yes?
Carotid stenting.
Coronary artery stents.
Carotid
Endarterectomy. Okay. So stenting of not only your carotids here, but then even coronary artery stenting, I would think, because you can develop clots. So when you've had a carotid endarterectomy and they've got a stent there, a lot of the stents now are drug-eluting stents, and so you have less common problems with those developing reocclusion and clot formation and plaque formation. So they've really gone a long ways in the past 10 years with this stenting. All right, hypercoagulable profile, so making sure that they don't have any hypercoagulable idiosyncrasies. So protein S, protein C, factor V Leiden deficiencies. Know those? All right. Stroke mimics. So these are, again, the post-ictal deficits. Where in the world? Ictal is seizures. Where did that come So a stroke will mimic with the paralysis because that can come back. A TIA especially is going to come back in a shorter period of time. Sometimes they'll even come to the ER and say, I had this, but now it's gone. Those patients, I usually will educate them to start on an aspirin a day and follow up with your primary care because they need to be worked up as far as finding out if they've got hypercholesterolemia, hypertension, all of those things, and making sure that those are managed aggressively because if they've had one TIA, more than likely they're going to have more TIAs. They need to stop smoking, they need to stop drinking, and exercise. If they're not walking and they're sedentary. So educating them on all of that. Stroke also mimics hypoglycemia as well. So hypoglycemia, somebody that's low on blood sugar is going to mimic having a stroke. They're going to have difficulty with concentrating, which is going to difficulty cause slurred speech sometimes. So don't jump on that bandwagon that they're having a stroke. Check their blood sugar. That's one of the first things when you've got an altered mental status, and that doesn't mean that they're comatose. They could just be having stroke-type symptoms. They're having a hard time speaking because they don't have enough sugar to their brain, and so therefore those synapses are not working, and they may not be able to finish their sentences, or they get confused when they get hypoglycemic. That's why it's really, really dangerous for somebody that is type 1 diabetic that's out of control to be driving. They'll get lost, just like our little man and lady with dementia. They don't know where they are and they can't be found. Those are the ones that also have Rett's, because they'll lose consciousness. All right, hemiplegic, aura, as well as acephalgic, so that just means that they're having a headache with the migraine. Hypertension, encephalopathy, I don't know what this is. I need to look into that. I'm just showing you how much I don't know. Okay. Reactivation of prior deficits due to a medical illness. Yes?
Posterior reversible encephalopathy syndrome.
Okay. Rare, I'm sure, since I've not heard of it. Mask lesions, because it's going to start affecting your neurological findings, which is going to mimic a stroke again. So make sure that you're getting that MRI or MRA as well. Subarachnoid hemorrhages, because blood loss to that area of the brain is going to act just like a stroke, because that's what a stroke is as well. Blood loss to that area of the brain is not going to function right. So these things are going to be similar in presentation, which will be on your differential as well as the stroke. Sometimes it's hard to differentiate those until you've got everything put together. Conversion disorder is the psychiatric one. That's the one earlier when I was like, I don't know why psychiatric is going to cause migraines and stroke type symptoms. All right, an un-TIA. Near syncope. These are all diagnoses that you can put, and they'll have an ICD-10. So these are not TIAs and not patients that are going to be at increased risk for having a CVA, which is a cerebral vascular accident, which is what a stroke is called. So just being confused or disoriented, again, not automatically a TIA. Syncope, not always a TIA. Make sure that you're going through anything, cardiac, that can be causing that. Arrhythmia, hypotension, hypovolemia, because they've gotten hypotensive due to their volume being low, due to dehydration, due to illness. So everything kind of runs together. Transient global amnesia. This is very, very rare. My mom had this as well. I know, I thought it sound like that. I'm a hypochondriac with my family. My family's a hypochondriac. I'd never heard of it until she was diagnosed with it. She literally had stroke-like symptoms, was at work, couldn't answer or talk to the phone. She was like in the middle of a conversation, and they called back after hanging up on her and talked to somebody else at her office and said, there's something wrong with the lady that I just talked to, because she was talking fine, and then all of a sudden she just started speaking weird. And so they went and checked on her, and of course she wasn't having a headache or anything, but she was just confused and having a hard time communicating. So they called my sister took her to the ER. My dad met us there. This was after when I've been practicing for 2-3 years. I met them to the ER, in the ER as well. We were in the waiting room. We were trying to get their attention to take her back because she was having all the symptoms of a stroke. Just with the confusion and the facial droop and the slurred speech. Didn't really have any other deficits as far as body or anything. But my dad was there and he went out to smoke. And so she turns to my sister and I and says, "You better call your dad, he's going to be pissed if you don't get in here." And we're like, "He was just standing in front of you." And that's when I was like, something's really wrong, this is weird. So they took her back, they treated her, worked her up for a stroke, treated her for a stroke, sent her down to a neurologist. And she actually didn't get any better with the treatment, with the TPA and everything else. And it was because of that. And he said it was very, very rare. People that do have it will almost never have it again. It completely resolves. We don't know what causes it. We have linked it a little bit to stress, but you guys can look at it on your own time. But yeah, it's the only one and only time I've ever heard of it. Vertigo, again, can be a TIA or stroke presenting symptom that progresses to that, but it doesn't automatically mean that it is. Here is the difference on a CT and how you would change the weight of that CT imaging. So this is called a distributed weight image, the one on the right, where see how it's easily lit up, and now that you see that one, you turn your face back over to the other one, and you're like, oh yeah, it is a little different there. See how hard it would be to pick up on with the regular CT imaging. So make sure that you play with your imaging and talk to your radiologist about how to pick up on early acute strokes, because sometimes it doesn't show up for 6 to 8 hours, but this is a TIA that was picked up, which means it was there and then went away. And vasospasms can cause TIA symptoms and light up but then go back away. So it's not going to be there for a long period of time. On your neurological examination, waving feet are going to be your best friend. So if you've got feet that they're laying in the bed with all of these other symptoms and one is tilted and the other isn't, as long as they haven't fallen and you're not suspicious of a pelvic fracture or a hip fracture, think stroke. Okay. Here's another case study. So we've got a 45-year-old female at the grocery store with her daughter, suddenly slumped over and became nonverbal at 4:05, 16:05. I didn't change this because I just went over it really fast last night. Her daughter called 911 immediately. They arrived in the ER in 15 minutes, so it's only been 15 minutes after onset. Noted to have global aphasia, so she was having a hard time communicating completely. Right hemiparesis was severe, and then they called stroke due to that being present. They were called at 4:30 while the patient was sent to the CT imaging to confirm it. So the next thing that I would be thinking of as soon as they get back to CT, and of course you're not going to send them to CT without a student that knows how to intubate, or yourself, just in case they deteriorate in CT. So I would have followed them to the CT and been right there with them with all of my equipment. So that means don't send them to the CT to die. Doesn't mean you can't send them to the CT. You just better have somebody there with capabilities of getting that airway if they start to cry. Okay? The next thing that I would be doing would be getting the paperwork and having somebody talking to the family, going through the contraindications, absolute and relative for TPA use. So you're thinking 2 steps ahead. All right. Upon stroke, physician's arrival at, we're at Bedpost at 4:50, so how much time has elapsed? 45 minutes, because it was 4:05. So make sure that you start training yourself what time it started and go from there. Keep that time in your head always. No hemorrhage, so obviously before you push TPA, you want to make sure it's not a hemorrhagic stroke. because if you push that, obviously you're going to make it worse. So we want an embolic or an occlusive stroke. That's when you would use an infarction. That's when you would use TPA. All right. What other questions do you have for the patient before you push it? So if you're going to push a clot velocity, are you already on a morphine? Do you have any bleeding disorders? What are their coagulation study results? So you would have already ordered that as well, obviously. PPINR, PTT, so that you know how to reverse it or know whether or not you're going to have other complications. Those are the things that are going to be on your questionnaire. Okay. I just wanted to see if you guys were thinking yet. All right. Blood pressure, slightly elevated, not massive. Rest of the general physical examination was normal. Finger stick blood sugar, they got that. Again, that's the number one thing that you want to make sure that you get before pushing the TPA. If you haven't had time to get your CMP back, obviously you would have sent that off to the lab, but go ahead and do the finger stick. That's immediate. You guys have done that. Good check, you know. And EKG was fine. CBC was negative, which means it was within normal limits, so we're not worried about platelets being abnormal, coagulation. The rest of that were pending. Patient confirmed, or the daughter confirmed that her mother was not on warfarin, heparin, or Lovox. Here's the risks and benefits. Again, this is something that you're going to be talking to your patients about. This is the bolus dosage that you're going to give over the next hour. And then it says that she had dramatic recovery during that infusion. CT of the head and neck was done urgently after TPA was started and showed no evidence of intracranial pressure increase or proximal left M1. So the middle cerebral artery occlusion, I guess. No. Inferior cerebral artery, that's what ICA is. Essentially, that's where it was prior to, and they just compared it before and after just for documentation. I'm assuming that's what they do at the stroke center. I transfer them. I don't do the post results. Get them stable, transfer them, and they do the rest of the workup. All right? Do not give full dose anticoagulation to acute stroke. Doesn't work. I mean, it must be something new. I've never heard of that. Obviously, why would you give Benadryl to somebody that you're going to give TPA to? Louder. I'm not going to decrease your grade for wrong. You got to learn how to own your answer, whether it's right or wrong. Because when you're out on your rotations and a preceptor asks you, they need to hear you.
There is any allergy?
Really good. We don't know. She's never had it before. She might have an allergic reaction, so we're pre-treating her. It's not going to hurt her. And we can reverse it if we needed to. IV Benadryl works fast, but it also clears out really fast. The only way you would reverse it would be to give her just more fluids to flush through her system. You're not going to give her a high dose of it, just minimal. Pepsid would be the other reason because of a possible allergy. But then, if we're going to give IV steroid, that's really caustic to the stomach, even if it is IV. So you're also giving Pepsid to help hit all of the histamine receptors for an allergic reaction, but then also protecting the GI. And then the epinephrine, obviously, if it's needed. they're saying this patient already developed angioedema, so it gave you the answer. So she was having angioedema after giving the TPA. Obvious, it's 1 to 2% of people that get TPA, but if they're in that 1 to 2%, you're going to make sure that you're on top of your game. Myasthenia gravis. You guys want to break?